Hi, I bring greetings to you from the Indian Association of Gynecological Endoscopics, and I'm extremely happy to be here in this particular event talking on the fertility enhancing aspect of hysteroscopic surgery. Well, at the outset, I declare I have no financial interest or obligation on the present presentation. Well, we all know that as a routine tool, hysteroscopy is always a matter of debate for evaluating infertile women because the effectiveness of this technique is still not yet proven, and more so because it was being done under anesthesia and, and the cost involved. But we all believe that in an ART cycle, the embryo culture conditions for the first 5 days is absolutely important for a growing blastocyst. But why not the anatomic factors which could affect the embryo and the fetus for the subsequent 9 months? And we rely on indirect methods of evaluating the uterine cavity, either by means of sonography or HSG and other indirect methods. Well, we know that today, with hysteroscopy being done in the office-based settings with a relatively low cost, the opportunities to improve fecundity through an accurate, gentle, rapid, and safe hysteroscopic examination is still underused. And this is published in the Fertility Sterility article by Keith Patterson and John Preston Parry et al. Well, we all can diagnose macroscopic features by the sonography, but what about these microscopic features like endometriosis, which is a leading cause in patients with recurrent implantation failure and patients with recurrent pregnancy loss? This all could never be diagnosed without the use of hysteroscopy. Well, presence of micropolyps, presence of focal hyperemia, presence of stromal edema, strawberry appearance, endometritic hemorrhagic spots. As you can see in the top video, a very shabby, unhealthy endometrium of chronic endometritis, mostly suggesting of tuberculosis, which is very prevalent in many parts of the world, like India and many parts of the African countries. You can see micropolyps, you can see unhealthy endometrium, those Langerhans cells deposits, which are very classically seen, and you can see the patient with a chronic endometriosis having the strawberry pattern of endometrium, and you can take a biopsy and then prove plasma cells presence, proving chronic endometritis or tuberculous endometritis, which will help you in diagnosing and treating the same before the patient is being taken for infertility treatment or for ART. Well, it has been a level A evidence that operative hysteroscopy improves the clinical pregnancy rate in women who have had diagnosed intracavitary abnormalities like polyps, submucous fibroid, and septum. Well, cutting the septum today is a much easier task with this thinner operative sheet without the use of energy, and all you need is this small 2 millimeter operative scissors, which of course has to be a little more sharper. And today, try and do the septoplasty or septal incision by the use of scissors and without using the Collins knife or energy. Well, the trick of doing incision on the septum is, of course, keep the blades horizontal and parallel to the tubal ostia, and you are justified today in cutting a septum in any patient with presence of septum, because we know that the presence of septum decreases the reproductive potential to a great extent, and the damage to the endometrium is very negligible, and bleeding is never a problem in most of the septum, and hardly 10 or 15% of septum do require some form of energy unless there is a very broad base or a very vascular septum. Well, there are enough papers to tell us that today the reproductive outcome in all forms of congenital uterine anomalies, be it uniconnuate, biconnuate, or didelphic uterus, is always decreased. The malpresentation rate is decreased, but the conception rate is never decreased in any of these abnormalities, excepting the septum, which is decreased. Even in patients with septum, it has been proven that the implantation rate and clinical pregnancy rate is much less, by this study by Pryor et al. In 2018 in the UOG journal, which clearly they took a two group of patients who had normal uterus and patients with congenital uterine anomaly in their evaluating patients who were for purely IVF and embryo transfer. And so you can see the numbers are also very good. And what they proved that patients with septum had a implantation rate of, or a clinical pregnancy rate just about 25% compared to the 43% of patients in patients with normal uterine anatomy or with arcuate uterus, and the live birth rate was a dismal 12% in patients with septate uterus compared to the 37% patients with the normal uterine cavity or patients with other form of congenital uterine anomaly, indicating that the presence of septum itself is an indication, even in patients who are going for IVF, that you are justified in doing the septal incision if you're doing preferably with the Caesars. Well, this dysmorphic uterus, or we call the classical T-shaped uterus, but this classification will help you differentiate between the two true T-shaped uterus and the infantile uterus, and one has to diagnose it by a 3D sonography. This lateral muscle thickness is what is going to decrease the pregnancy rate and the full-term delivery rate to 21%. And you, apart from this, which is in the normal cavity, and this is where the 3D picture will tell you that the T-shaped uterus has got a normal narrow volume, and cutting it with the same 2 millimeter Caesars is a trick. Though the muscle is a little more thicker, avoid using the energy. And what you need is to just fix the blade, one of the blade of the Caesars into the lateral myometrium and move the other blade in cutting the same. And definitely over a period of time, you will find that it is easier to cut even in the lateral walls. And the advantage is you are not damaging the endometrium, but make sure that you start cutting above the internal os and not at the internal os to prevent the incompetent cervix. On both the sides, if you cut properly after proper diagnosis by 3D sonography, you can see the increase in volume. And this was a nice article published by Attilio Sardo et al., published in the JMIG, which they proved that if selected patients, there not only the spontaneous pregnancy rate improves in patients who have had infertility after the lateral metroplasty, but the live birth rate improved to almost 80%. And even in patients with recurrent spontaneous pregnancy loss, it was close to 78% after judicious use and selection of patients who require lateral metroplasty in a properly diagnosed T-shaped uterus. Well, the evidence that the submucous fibroid is going to definitely impair your implantation is a very strong evidence, and it's a grade A recommendation that in patients with otherwise unexplained infertility, removing the submucous fibroid is definitely indicated will improve the clinical pregnancy rate, and the quality evidence is also good. And today, undoubtedly, hysteroscopic management of submucous fibroid is what is recommended. It's a grade B recommendation, and one has to know the trick of doing a safe myomectomy because of the chance of fluid overload in patients with large submucous fibroid. So the cutoff limit, though is set in about 5 centimeters, occasionally we do go above, but one must remember that there is always a second day in an hysteroscopic procedure. You can abandon the procedure if there is fluid overload and do the procedure on a subsequent setting. But remember that you should not damage the adjacent endometrium in patients who are for the hysteroscopic submucous resection. Well, the margin where to stop is all easily identifiable by the by the circular pink fibers, and you can identify the whitish capsule of the fibroid. And we prefer to use the bipolar current most of the time for the safety aspect of the distension media, that is ringalactate or saline. And we are usually happy with it today, and we would recommend that monopolar be used less in hysteroscopic surgery. And one must do a complete job, and you can identify the presence of small capsule in this patient, posterior myoma, which is there. You can just cut it, and the adjacent normal-looking myometrium is very easily identifiable. Well, whether to use the intrauterine retrieval system, which is all available, morcellators are being marketed, but the studies published data are very limited to find out whether morcellation is better or use of receptoscope is better. But it is a good option only for type O and type 1, though those who are advocating claim that the damage to the endometrium is much less. But most of us are very comfortable using the receptoscope, but maybe the cost is what is inhibiting us from using these morsel later, but may be a good option in patients who are reproductive age group where the cost is not a big concern. Well, what is the interval post-hysteroscopic surgery to allow a patient to conceive? Generally, polyp heals the fastest. A month is enough. Septum the slowest. One should wait for 3 months for the endometrium to grow there. And myomectomy, one would advise 2 cycles, where Asherman's depends upon the severity. And we all know that the incidence of Asherman is increasing by the day because of more of use of hysteroscopic procedure. Well, we know that Asherman is totally an iatrogenic disease, and the earlier you diagnose that Asherman could have been caused by doing the judicious use of DNC, we can see that if you pick up early, the adhesions which are just getting formed get disturbed by the distending media and they break. And even if there is a delay of a couple of weeks, it's still okay. You can see in this video that the rest of the endometrium still looks very pink. And though the endometrial adhesions are a little more dense, they are still very superficial. And cutting them with the scissors is a very, very easy option. And one must remember that you are restoring the normal anatomy of the uterine cavity in the endometrium at the end of the procedure will be very healthy and as good as a normal woman. And definitely the chances of pregnancy improves to close to 90% with a live birth rate reported in patients of mild or moderate Asherman's is close to 77%. So picking up Asherman's early is always the key. And unless you have delayed the diagnosis because of the patient coming late to you, where the anatomy itself is not identifiable, internal loss, such an important aspect in identifying the right uterine cavity, seems to be obliterated in these patients who has come to us after 3 years of the damage by DNC. You can see you can't identify the internal loss, but you have to follow those mucosal folds which are there in the cervix, and the same 2 millimeter scissors, judiciously cutting small, judiciously opening up the blades will allow you to enter in the right plane. And definitely the delay in diagnosis and the patient comes with severe Asherman, the live birth rate drops to just about 33%. But our job is to follow the anatomy, identify remember the uterine anatomy, that this uterine cavity is an inverted triangle. And you can see the cavity coming up here. It's an inverted triangle with the apex at the internal os and the base at the level of the tubal ostia. Our job is to create a pure, beautiful cavity. And these shreds which are hanging down has to be all cut. You can see the whole cavity now being formed, and even you can identify the tubal ostia. So of course, definitely the problem of implantation and clinical pregnancy rate drops in these patients. You have to use some form of adhesion prevention strategy in patients with severe Asherman. And today it's a level A evidence that intrauterine balloon stent or a pediatric Foley catheter, because of the cost involved, which is much cheaper with a 3 ml, 8 or 10 pediatric Foley catheter for 5 to 7 days has been proven to be of benefit. But the factors which predict fertility after Asherman is the time duration between the first causative factor and your treatment. More the delay, less are the chances. Return of normal menstruation, cervical adhesions, if they are present, they are going to cause more infertility, and recurrent patients who require recurrent extraadhesiolysis have a less chance of a healthy pregnancy. Well, we all are now getting used to this particular use of the platelet-rich plasma or the stem cells, and we believe that under hysteroscopic guidance, the material derived after PRP, if you inject under vision to all the 4 walls of the uterine cavity. Of course, these are right now on the experimental basis. Only time will tell whether instillation of stem cells or PRP will help that damaged endometrium to regenerate, but you can do it under hysteroscopic guidance with the same ovum pickup needle which we use. Well, time to pregnancy, it is important for patients, but we doctors underestimate. And many couples who abandon the treatment after one IVF treatment because of the psychological burden. So is it not our responsibility that today hysteroscopy is evolving an ambulatory hysteroscopy is very possible. It's time to rekindle that expertise for the benefit of our patients. You can today see that patient under no anesthesia, undergoing an operative procedure with energy using the smaller diameter Kubini receptoscope, and you can perform, you can see the patient talking to us during the procedure. So that's where the invasiveness of the anesthesia and the cost involved has become much less. Hence, friends, it is for us to conclude that today that hysteroscopy should be evaluated, since its execution at specific steps and clinical workup and therapy may improve the reproductive outcome of infertile couples. And I would recommend that one should all know how to do a hysteroscopy when you're dealing with infertility patient. And I thank you for a very patient hearing. Thank you so much.